Hi, I'm Fahad Khalik and welcome to Golden Nuggets for Gynecology. Now, the first thing is that low estrogen is going to inhibit the LH secretion. This is negative feedback and the mechanism is unknown. The same way, high estrogen is going to increase LH. This is an example of positive feedback and this is because of the receptor concentration. Low progesterone is going to increase FSH and LH. This is positive feedback and this is mediated through sensitivity. The same way, high progesterone is going to inhibit the FSH and LH, and this is an example of negative feedback, and this is mediated through sensitivity and production. In the ovarian cycle, you get the follicular phase. This accounts for the first 14 days. Then you get to see the ovarian phase, and this starts 24 to 36 hours after ovulation. And finally, you get the luteal phase, and this is going to last for the last 14 days. Initially, the follicles are independent, and in later phases, the follicles are dependent on FSH. Now, this is the summary. You get the FSH secretion from the pituitary, which is going to stimulate the follicle. The follicle has theca and granulosa cells. When you stimulate the granulosa cells, these are going to produce activin. Activin is going to increase the binding for the FSH. One more thing from the granulosa is the anti-Mullerian hormone, and this is going to tell you about the ovarian reserve. Granulosa cells are also going to produce the progesterone, and finally these granulosa cells are going to produce the inhibin. Now this inhibin is going to decrease the production of FSH through the negative feedback loop, and this inhibin is going to increase the production of androgens. Now, the second part of the story is the theca cells. These are going to produce the androgen, and these androgens account for 30 to 50% of the total androgens in the body. And finally, these androgens are changed into estrogen. Now, this is through the process of aromatization. What happens is this FSH, or you can say this FSH, is going to stimulate the granulosa cells. Then these granulosa cells are going to convert these androgens into estrogen, and this is called aromatization, and that's going to happen in the periphery tissues. This estrogen is going to inhibit the production of this FSH through the negative feedback loop. Leptin GPR54 is related to delayed or absent puberty. On the 14th day, you're going to see the dominant follicle, and that measures 20 millimeter in diameter. High estrogen is going to increase the LH surge, and this is going to take 24 to 36 hours. Luteal is defined as the last 14 days where there's a decrease in the beta HCG concentration. In the follicular phase, you're going to have increased FSH and decreased progesterone and inhibin. In the luteal phase, you're going to have decreased FSH and LH and increased progesterone and VEGF. As I already said, in the luteal you're going to have decreased beta HCG, and this is going to happen in the last 14 days. In the menstruation, you have decreased progesterone. The menstrual cycle has three phases. First is the proliferative phase, and that's because of estrogen. Then you get to see the secretory phase. This is because of progesterone. And actually, which is the first day of the menstrual cycle, is the menstruation phase. In proliferation, the size of the layer increases from 0.5 millimeter up to 5 millimeter, or you can say from 0.5 to 3.5 to 5 millimeter. If you talk about the proliferation, there's increased thickness in the endometrium. If you talk about the secretion, you get the glands, arteries, fluids, and decidua. Pinopods are going to appear after 21 or 22 days. Menstruation starts on first day and menstruation ceases at fifth or sixth day. Now, if you talk about the layers of endometrium, you get the lowest layer, which is basalis, and this accounts for 25%. Any damage to the basalis is going to lead to Asherman syndrome. Then you get the stratum spongiosum. This is going to have glands and stroma. And then finally, the topmost layer is the stratum compactum, which is going to have the decidualized stromal cells. Vaginal bleed ceases within 5 to 10 days. If you talk about the bleeding, that's because of vasoconstriction. And what's really involved is prostaglandin F2 alpha, endothelin 1, platelet activating factors, COX, and some chemokines. Now, if you want to control this bleeding, you have to give the vasodilators, for example, PGE2, prostacyclins, nitric oxides, and COX inhibitors, for example, NSAIDs. For the endometrial repair, the natural chemicals in the bodies are VEGF, FGF, EGF, IGF, TGF, and some interleukins. Gonadotrophin releasing hormone pulses start at the age of 8 or 9 years, and the onset of puberty is related to leptins. First sign of puberty is the breast budding. This is very important, and this is seen 2 to 3 years before the start of menstruation, which is menarche. Now, the mean age of menarche is 12.8 years, and it's going to take 3 years to establish a proper or regular cycle. Breast scoring system, first of all, you have the prepubertal stage, then you have small mounds, then you're going to lose the areola breast contour, secondary mount appears, and finally you're going to have contour on the areola part of the breast. If you talk about the pubic hair scoring system, first stage is prepubertal. Then what's going to happen is you're going to have hair on the labia majora. Then these hair are going to extend onto the mons. And finally, there's increased amount of the hair. They're going to get curly and coarse. And finally, they're going to achieve this triangular shape up to the thighs. Precarious puberty in the girls is defined as the puberty before 8 years of age, and the precarious puberty in the boys is defined as puberty before 9 years of age. Delayed puberty is no puberty scenes even up to 14 years of age. In the primary amenorrhea, girl fails to menstruate by the age of 16 years. In secondary amenorrhea, there's a positive history of menstruation, but there's subsequent no menstruation for 6 months, and you have to exclude pregnancy, lactation, and menopause. Oligomenorrhea is defined as 4 to 9 periods a year, plus you're going to have irregular periods for more than 35 days. POF is the cessation of periods before 40 years of age. In POF, you're going to have increased FSH, while in PCOS, which is polycystic ovarian syndrome, you have increased LH, or you can say you can have increased LH to FSH ratio, and there's increased amount of testosterone. Now, the ultrasound criteria for PCOS, you're going to have 8 or more cysts, and the size of those cysts is going to be less than 10 millimeter, and there's increased stoma. PMS hormone is rotentin, and the causes for the abnormal uterine bleed is palm coin, which is just polyp, adenomyosis, leiomyoma, malignancy, coagulopathy. You can have ovulatory diseases, endometrial causes, iatrogenic causes, and some causes which are just not classified. Heavy menstrual bleed is more than 80 milliliter of blood per period. Postmenopausal bleed is defined as the bleeding for more than 1 year after menopause. Prostaglandins are the cause for the bleeding of endometrial origin, or you can say dysfunctional uterine bleed. For the endometrial biopsy, you should have a patient with the age more than 45 years. And the second indication is the thickness of endometrium more than 4 millimeter on transvaginal ultrasound sonography. You're going to go for hysteroscopy in a patient with a heavy menstrual bleed, and the age of the patient should be more than 45 years, and there is more than 4 millimeter thickness of endometrium on transvaginal ultrasound sonography. There's a positive history of heavy menstrual bleed or intermenstrual bleeding, and there's history of previous treatment failure, or if you're just planning for the ablative therapy, you have to go for the hysteroscopy first. Now, if you're using Mirena, it can cause median menstrual blood loss reduction within 1 year. If you plan to treat the heavy menstrual bleed with the northestrone, the dose for it is 15 milligrams per day for 6 to 26 days. For endometrial ablation, first thing, size of the uterus should always be less than 10 weeks. And second thing, you can do it for all the fibroids which are less than just 3 centimeter. The treatment of fibroids in patients who wish to conceive, you can go for myomectomy, or you can just go for transcervical resection of fibroids, which is just TCRF. Primary dysmenorrhea is the painful menses since birth. Secondary dysmenorrhea is the painful menses developed over time, which is just second to some cause. The first line treatment for dysmenorrhea, which is just painful bleeding before laparoscopy, is levonorgestrel releasing intrauterine system, which is just called Mirena. Fertilization usually takes place in the proximal tubule, which is the ampulla, and 7 days after fertilization, you're going to have implantation in the endometrium. The corpus luteum is going to support pregnancy for the first 8 weeks, and that's going to support through progesterone. Beta HCG in the urine is seen 1 to 2 days before expected menses in a pregnancy. Now, what is a biochemical pregnancy? It's an early miscarriage. There is egg implantation, but that implanted egg fails to develop. So there's implantation, but there's no development. There's a positive pregnancy test. You're going to have high levels of beta HCG, but there are no features of pregnancy. There's menstruation 1 to 2 days after the expected date, and the subsequent pregnancy test is going to be negative after the menstruation. Through the transvaginal ultrasound sonography, you're going to see the sac, which is just the first sign of pregnancy, and it's seen at 5 weeks. Few days after 5 weeks, you're going to see the yolk sac. At 5.5 weeks, you'll see the fetus, and at 6 weeks, you're going to see the heart beating inside the sac. Beta HCG doubles every 48 hours, and the beta HCG for a normal pregnancy, which is just the intrauterine pregnancy, is more than 1500 units. Miscarriage is the loss of pregnancy before 24 weeks internationally, while in Pakistan, you're going to see this loss before 28 weeks. If you talk about the types of miscarriage, you have threatened miscarriage, in which there's positive fetal heart and the cervical os is closed. In the inevitable miscarriage, this is exactly the opposite. There's no fetal heart and the os is open. In the incomplete miscarriage, you're going to see retained products of conception and the os is open again. In the complete miscarriage, you're going to see completely empty uterus and the os is completely closed. If you talk about the missed miscarriage, you have no fetal heart, and this is usually asymptomatic. After you go for the expectant management for the miscarriage, you have to go for the urine pregnancy test 3 weeks after the management. If you want to go for abortion at 9 weeks, you can choose misoprostol and mifepristone combination. Now, loss of more than 3 consecutive pregnancies is defined as the recurrent miscarriage. And the treatment for recurrent miscarriage is to treat the underlying cause, which can be treated by the aspirin, heparin surgery. You can just donate your gametes. You use the steroids, progesterone, or metformins. Ectopic pregnancy is defined as a positive pregnancy test, and you're going to see empty uterus and adnexal mass on the transvaginal ultrasound sonography. Now, this is very important. This is adnexal mass. If you see the adnexal tenderness, this is going to be pelvic inflammatory disease, which is a main differential for this ectopic pregnancy. What is pregnancy of unknown location? You have a positive pregnancy test, you got the empty uterus, and there's no adnexal mass on the transvaginal ultrasound sonography. Ectopic pregnancy, if you want to treat it medically, you can go with the methotrexate, and the criteria should be adnexal mass that measures less than 40 millimeters. Beta HCG should be less than 3000, and there are minimal symptoms, and the patient should be hemodynamically stable. Then you're going to repeat the beta HCG on the 4th day, 7th day, 11th day, and then subsequently you're going to check it. From 4th day to 11th day, you're going to see the 15% drop. And then again, you're going to see more drop between 7th and 11th day. And then you will have to monitor it weekly. And between every 2 readings, you're going to see drop in the beta HCG. After you go for the methotrexate treatment for the ectopic pregnancy, you should avoid intercourse for at least 3 months. If you choose to go with the surgical management of ectopic pregnancy, you will use anti-D prophylaxis and you will give 250 international units in 72 hours. Subfertility is defined as inability to conceive after 12 months of regular intercourse. In primary subfertility, the couple is always trying, but they are never conceiving. If you talk about the pregnancy achieving rates, if a couple goes for unprotected intercourse for 6 months, there's a 75% chance of achieving the pregnancy. Similarly, if they go for 1 year intercourse, there's a 90% chance. And if they go for 2 years intercourse, there's a 95% chance of achieving the pregnancy. Now, if you plot a graph of quality and quantity of eggs in a female, you get the two dips in the graph. First dip you're going to see at 36 years, and the second dip you're going to see at 40 years. In males, the frequency of intercourse declines by the age of 40 years, and in males, you're going to see fall in the semen quality by the 50 years of age. Now, the egg in the female is going to remain fertilizable 12 to 24 hours after ovulation. The sperm is going to survive in the female for 72 hours. Ovulation is seen 14 days before menses. Implantation problems and heavy bleeding is seen in the submucosal fibroids. You're going to see reduced fertility in the large intramural more than 5 centimeter fibroids, and you'll start investigating after 1 year of subfertility. To check for the ovarian reserve, you can go with the anti-Mullerian hormone, or you can just go with the antral follicle count. Now, the AMH, which is secreted by the granulosa, is the best marker for ovarian reserve because it doesn't vary with the cycle. And if you choose to go with the AFC, which is going to predict ovarian response, if the reading is less than 14, this is going to tell the low ovarian response. If you get it more than 16, it means there's a high ovarian response. Ovarian reserve decline after 35 years. Semen fluid analysis. First, you should not ejaculate 2 to 4 days before test. The lower limit is 5th centile, and if the test comes out to be abnormal, you should repeat it after 3 months. Now, what are the normal values for SFA? The volume should be more than 2 milliliters, pH should be 7.2 to 7.8, the concentration should be more than 20 millions per milliliter, the normal morphology should be more than 20%, motility should be more than 50%, liquefaction time is round about 30 minutes, and the total sperm number should be 40 millions per ejaculation. Now, the beta HCG and LH both have same alpha subunits. That's why you can use beta HCG injection to mimic the LH surge. Menopause is the cessation of menses, and the median age for the menopause is 51 to 52 years, while the range for the menopause is 45 to 55 years. Both the values are very high yield. Climacteric, which is perimenopause, is defined as the time from ovulation dysfunction to 1 year after LMP, which is the last menstrual period. Postmenopause is the duration of 1 year since LMP, and confirmed menopause is again the duration of 1 year since LMP. Androgen concentration gets half from 20 to 40 years. And in menopause, you're going to see the increased FSH and decreased estrogen. The FSH should be higher than 30. In the perimenopause, you're going to have increased GnRH, LH, FSH, and decreased estrogen, progesterone, inhibin, and testosterone. In the early menopause, you have increased FSH and LH. Progesterone cannot be relied upon, and there's decreased GnRH, estrogen, inhibin, and testosterone. While in the late menopause, you're going to have progesterone, which is undetectable. The same goes for the inhibin, which is again undetectable, and there's decreased GnRH, FSH, LH, estrogen, and testosterone. Premature ovarian failure is defined as a cessation of menstruation before 40 years. In the osteoporosis, bone mass increases after birth, and it peaks at 20 to 30 years. After 20 to 30 years, there's steady decline until menopause. After the menopause, there is accelerated decline up to 60 years, and after the 60 years, again there is decline that is steady. So bone mass increases after birth, peaks at 20 to 30 years, then there's steady decline until menopause, and from the menopause to 60 years, there's accelerated decline, and after 60 years, there's again steady decline in the bone mass. After menopause, the weight increases by 1 kilogram per year. Non-hormonal treatment for vasomotor symptoms is alpha-2 agonists. For example, you can use clonidine. Beta-1 blockers, for example, you can use propranolol. And SSRIs, for example, you can use sertraline for the treatment of vasomotor symptoms. You can use levonorgestrel releasing intrauterine system, or just Mirena, for 3 C's. The first C is contraception. You can use it for contraception. You can also use it for the treatment of cancer, for example, endometrial carcinoma, and the protection is going to last for up to 5 years. The third C is coagulation. For example, you're going to use Mirena in the treatment of heavy menstrual bleed and intermenstrual bleeding. Now, the HRT dose which is going to cause cancer is 10 microgram twice weekly, while the actual or the normal dose for the HRT is 1 milligram over a year. Perimenopausal or early menopausal period is defined as a window of opportunity in CVS if you talk about the HRT. AMSA's criteria for Gardnerella vaginosis: first, you're going to have Fichy odor, you'll have glue cells, this increase in the pH, this is very important. And then finally, you're going to have homogeneous discharge. The commonest cause for the vaginal discharge is bacterial vaginosis. The gold standard investigation for Trichonoma vaginalis is NAAT. Commonest bacteria for STI under 25 years is chlamydia. You're going to treat pelvic inflammatory disease for 2 weeks. In the third trimester, especially last 6 weeks, you have high risk for neonatal herpes. HPV 6 and 11 are going to cause the genital warts, while the HPV 16, 18, 31, 33 are going to cause cervical cancer. The bivalent vaccine for HPV is against the HPV 16 and 18, while the quadrivalent vaccine is against HPV 16, 18, and 6 and 11. Now, there are some high yield associations with syphilis. It's going to cause chancres, gumma, eighth nerve palsy, uveitis, interstitial keratitis, meningitis, aortic regurgitation, which is secondary to involving of aorta and which is going to cause the tree bark appearance. Similarly, with the syphilis, you're going to have tabes dorsalis, paresis, paralysis, raggeds, Clayton joints, Hutchison's teeth, mulberry molars, bossing. Same way, you're going to have high palatal arch and paroxysmal cold hemoglobinuria. The detritus muscle is supplied by the parasympathetic nervous system, while the sphincter is supplied by the sympathetic and somatic nervous system. If you deliver a baby that weighs more than 4 kilograms, or you can say a macrosomic baby, you have a higher risk for the sphincter incontinence. If you take excess fluids more than 2.5 liters, you'll have increased frequency, while the urgency is associated more with the low fluid intake, and the normal fluid intake should be 1.5 to 2.5 liters. Normal urine production rate is 1 to 2 milliliter per minute, and the normal bladder capacity is 300 to 500 milliliters. Now, when the bladder is filled with 150 milliliter of urine, you're going to experience some sensations. When the bladder is filled with 300 milliliters of urine, you'll have strong desire for the micturition. And when the bladder is filled with 500 milliliters of urine, you'll have urgency. TVT sutures, you're going to give 2 suprapubic incision, and the region is going to be retropubic space in the mid-urethral region. Then you're going to apply the sutures through the urogenital diaphragm in the rectus sheath. While in the TOT sutures, you're going to give 2 incisions in the groins, 1 incision in each groin. The region is going to be obturator foramina, mid-urethral region, and you're going to apply the suture through the obturator muscle and the adductor longus muscle. In the colpus suspension, you're going to give the fan steel incision. The region is going to be the neck of bladder, and you're going to apply the interrupted sutures through the paravaginal fascia and the pectineal ligament. In the first line, you're going to use TVTs and TOTs. In the second line, you're going to use the colpus suspension, while in third line, you can think about the bulking of the region. The botulinum half-life is for 3 to 6 months. Digitalization is defined as the reduction of prolapse by the fingers. Levator ani muscle is made up of puborectalis, pubococcygis, and ilococcygis muscles. And the puborectalis muscle is going to make the urogenital hiatus. If you talk about the levels of ligament, you have the uterosacral ligament, and this is going to cause the vaginal vault or prolapse, or you can say apical prolapse. It means the uterus is going to prolapse into the vagina. The second level is pubocervical, or you can say the rectovaginal ligament, and this is going to cause anterior or posterior vaginal prolapse. And in this, the vaginal wall is going to prolapse into the vagina. The third level of ligament is posterior vaginal or the perineal body, and this is going to cause the lower posterior vaginal prolapse. If you talk about the stages of prolapse, at first stage, the prolapse doesn't reach hymen. At second stage, it reaches the hymen. And at third stage, it crosses and goes beyond the hymen. Now, very important thing is when a woman undergoes hysterectomy, she is at highest risk for vault, or you can say apical prolapse, and the treatment for this is sacrocolpopexy, which is just the placing of mesh between sacrum and cervix. The conservative treatment for the prolapse is exercise, use of pessaries, and sacrohysteropexy. Now, if you want to use the pessaries, you should have an intact perineal body. Now, when your perineal bodies are damaged, you can still use shelf and Gillhorn pessaries. So, shelf and Gillhorn pessaries are used in patients with the damaged perineal bodies. Now, the surgical treatment for the prolapse, if you get the uterine prolapse, you can go for vaginal hysterectomy. If you get cystocele, you can go for anterior repair. And if you get the rectocele, you can go for the posterior repair. TVTs and TOT sutures are for incontinence. They are not for prolapse. Now, if the size of ovarian cyst is less than 7 centimeter, you're going for the conservative management. Cyst is defined as something which has size more than 2.5 centimeter, and if the size is less than 2.5 centimeter in the ovary, it's just a follicle. Benign ovarian cyst, we have a mnemonic which is E, F, G, STAX, and I. E stands for epithelial cyst. These are benign ovarian cyst. F, functional cyst. G stands for germ cell cyst. Sex cord, these are also type of benign ovarian cyst. And finally, you get the inflammatory cyst, which belong to benign ovarian cysts. Now, CA125 is going to tell you about the borderline and serous epithelial carcinoma. The same way, CA19-9 is going to tell you about the borderline and mucinous epithelial carcinoma. Inhibin is related to granulosa. Beta-HCG is going to tell you about choriocarcinoma, and dysgerminoma and alpha-fetoprotein is going to tell you about the yolk sac and teratoma. Endometrioma, oma means mass. Endometrioma means glands and tissue of endometrium outside the endometrium, and in this case they are inside the ovaries, and you're going to see the chocolate cyst, ground glass appearance, and kissing ovaries. 90% of the dermoids are unilateral, 98% are benign, 15% are associated with torsion. If the size is more than 5 centimeters, you're going for the surgery. Serous cyst adenomas, these are unilocular and these are unilateral, while the mucinous cyst adenomas are multilocular and they're bilateral. Brenner tumors are the estrogen secreting tumors. They are made up of urothelium, while the fibromas are associated with the Meek syndrome. It means you get the fluid in the pleural space and other compartments of the body. Thecomas are going to secrete the estrogen and they are associated with the postmenopausal bleed. Fimbrial, or you can say paratubal cysts, these are cysts in the fallopian tube or the broad ligament of the uterus. Cysts of Morgagni, these are grape-like cysts and are from paraoophoron. If you talk about the endometriosis, it means glands and stromas of endometrium outside endometrium, and you're going to see the ligaments which are thick and nodular. The pouch of Douglas is tender, uterus is fixed and retroverted, and there are lesions which are puckered and mastix-like. If the size is less than 5 mm, it's best to go with the ultrasound. If the size is more than 5 mm, the MRI is going to pick it up better. Luteolysis is related to the secretion of PGF2. Chronic pelvic pain is the pain that can be intermittent or chronic in the lower abdomen for more than 6 months. In the chronic pelvic pain, the first line investigation is transvaginal ultrasound sonography. Laparoscopy is the gold standard, and you can go with a 3-month ovarian suppression trial of hormones. Cervical ectropion is defined as the columnar cells outside the cervix. Normally, there are columnar cells inside and stratified squamous cells outside. But when these columnar cells go outside the cervix, this is called cervical ectropion. It's related with the puberty pill and pregnancy, and there's clear, odorless, mucinous fluid. Nipothian follicles are the trapped columnar cells, and these are mucus-filled cysts. Cervical polyps, these are smooth, red protrusions of the columnar cells. And the cervical stenosis is defined as the narrowing canal, which is ultimately going to cause the cyclical dysmenorrhea. Now, if you talk about the polyps, polyps are the cycle independent. That's why they're going to cause unscheduled bleeding. 10 to 15% polyps are hyperplastic, and 1% polyps are malignant. Cervical fibroids are related to the abnormal lie of the fetus, and the submucosal fibroids are related with the infertility and heavy menstrual bleed. Now let's talk about the treatment for the fibroids. Now, if the size of the uterus is less than 12 weeks, you can go with the conservative treatment. For example, you can go with the oral contraceptives. Mirena, you can go with the tranexamic acid and mefenamic acid. If the size of the uterus is more than 12 weeks, you can go with the GnRH or SPRM. In the surgery, you can have minimal invasive hysterectomy or myomectomy or hysterectomy. Radiologically, you can go for uterine artery embolization, MRI guided ultrasound, and ultrasound guided radiofrequency ablation. In the adenomyosis, you can see bulky, boggy uterus with the irregular nodules. There's some hemorrhage with the distended glands. The investigation of choice for adenomyosis is MRI, and the treatment for adenomyosis is Mirena, GnRH, and hysterectomy. Now here's a summary for the epithelial linings. For example, in the uterus, you have simple columnar epithelium. In the cervix, you have normally collagen, but the cervix is really divided into endocervix and ectocervix. In the endocervix, you have columnar epithelium. In the ectocervix, you have stratified squamous non-keratinized epithelium. If we talk about the labia majora, you have stratified squamous keratinized epithelium with the hair, sweat, sebaceous glands. In the labia minora, you have stratified squamous keratinized epithelium with only sebaceous glands. In the vestibule, you have stratified squamous non-keratinized epithelium, while the ducts of the labia majora and minora are made up of transitional epithelium. Bartholin ducts are located at 5 and 7 o'clock position. The vulval skin loses twice more amount of water because of the thin stratum corneum. Now for the treatment of candida of vulva, you have drug of choice, which is 150 milligrams of clotrimazole for 3 nights, and the second line treatment is just the fluconazole. Now the itching in the vulva is associated with the low ferritin levels. Keys bunch biopsy is used for the erythro or leukoplakia, and it's going to take 4 millimeter deep sample. Now there are some important points about the lichen planus. In the mouth, you're going to see reticular cobwebs. In the nails, you'll see long ridges in the sandpaper effect. In the genitals, you're going to see the lesions and stenosis. In the lichen sclerosus, you have the parchment paper skin, which you can call hyaline skin. You have phimosis and figure of 8 pattern. Most common vulval skin is the Bartholin cyst. Dyspareunia is the pain during intercourse, and the superficial dyspareunia is related to the vagina, clitoris, or the labia. And for the investigation, you will go for the biopsy and swab. While in deep dyspareunia, the causes are mostly related to the pelvis, and for the investigation, you're going for the transvaginal ultrasound sonography, swab, and laparoscopy. In the primary psychosocial dysfunction, you get the psychosomatic pain, while in the secondary psychosocial dysfunction, you get the pain along with the emotional issues. If you talk about the FGM types, in the type 1 FGM, you're going to damage the clitoris hood. In type 2, along with the clitoris, you're also going to damage the labia majora. In type 3, there's complete external genitalia damage and you're going to stitch the vaginal infundibulum. In type 4, there's piercing, burning, cautery, or cutting of the external genitalia. Also, the use of corrosive material on the external genitalia belongs to type 4 FGM. Now, the type 3 FGM is associated with the obstructed labor and CKD, and the treatment for that is episiotomy and deinfibulation. And it's illegal to resuture an FGM. Now, the ovarian carcinoma originates not from the ovaries, but from the distal fallopian tube precursor lesion called STIC, which is just serous tubal intraepithelial carcinoma, and that's because of mutation in p53 gene. If you talk about the ovarian tumors, you got the mnemonic GAMS. For example, G stands for germ cell tumors, E stands for epithelial tumors, M stands for metastatic or METs, and S stands for sex cord tumors. So these all belong to the ovarian tumors. Now, the borderline serous tumors are going to make the major type of borderline ovarian tumor, or you can say BOTS. Now, the borderline mucinous tumor arises from the pendicular carcinoma. High grade serous tumors are the most common ovarian cancer, and they're going to make 75% of all types of ovarian carcinomas. They are associated with the psammoma bodies. Mucinous carcinomas are associated with the pseudomyxoma peritonei. Endometrioma, oma means mass, so this is just the gland and stroma of endometrium outside the endometrium. In this case, it's going to be ovary. So endometrioma is associated with endometriosis. Clear cell carcinoma arises from endometriosis. Ovarian cancer biopsy site is always the omentum. Now, the most important prognostic factor for the ovarian carcinoma is no residual disease left behind after the surgery. Now, if you use the platinum in the treatment of ovarian carcinoma, it's going to block the DNA cross linkages. As a result, there is no cell division. And always remember, carboplatin is superior to cisplatin. Paclitaxel is going to damage the microtubule, so there's no replication and division. Bevacizumab is an anti-VEGF monoclonal antibodies and it's going to inhibit the angiogenesis. After initial treatment, if there's remission before 6 months, you're going to use taxols and doxorubicins. If after initial treatment there's remission after 6 months, you're going to use carboplatin. So before 6 months, taxols and doxorubicins. After 6 months, you're going to use carboplatin. Sex cord tumors can be estrogen secreting or androgen secreting. Now, the estrogen secreting sex cord tumors are granulosa, theca, and Sertoli cells, and the androgen secreting sex cord tumors are lytic and steroid cells. 99% of teratomas are benign and 1% are just malignant. Now, what is the treatment for the germ cell tumors? You can go for the surgery and post-op chemotherapy, which includes bleomycin, etoposide, and cisplatin, which is just BEP. Now, 75% of endometrial carcinomas are seen after menopause, or you can just say after 62 years. If you talk about the type 1 endometrial carcinoma, it's seen in 80% of cases. It's just an adenocarcinoma. It's estrogen dependent, and that's because of hyperplasia. Now, the type 2 endometrial carcinoma is seen in 20% of cases. It's just serous and clear cell carcinoma. It's estrogen independent, and that's related to atrophy instead of hyperplasia. Now, in histology, you can go for the type and grading. If you go for the type, it can be endometrioid or some other type. Now, there are some important findings in the endometrial carcinoma. First, if you go for the cervical smear, you're going to have abnormal glandular cytology. In endometrial carcinoma, you can have cervical smears, and in the smears, you're going to see abnormal glandular cytology. You can examine bleeding through the cervical os, and on examination, you will see the bulky uterus, and through the transvaginal ultrasound sonography, you're going to see more than 4 millimeter thickness in endometrium. Leiomyosarcoma is the malignant transformation of fibroid, which is just leiomyoma. So leiomyoma changes into leiomyosarcoma. Now, the mixed epithelium sarcomas are seen after menopause, they're seen after radiation, and they're seen as a fleshy mass protruding outside, and the uterus is going to be soft and large. Rhabdomyosarcoma is characteristically seen in the children with a grape-like mass with a watery discharge, and on histology you're going to see the rhabdomyoblast. If you talk about the cervical intraepithelial neoplasia, you have scene 1, 2, and 3. In the 1, you get the 1/3 thickness involved. In scene 2, you get the 2/3 thickness involved. In scene 3, you get less than entire thickness involved. And in cervical carcinoma in situ, you get entire thickness involved, but the basement membrane stays intact. National cervical screening is done every 3 to 5 years for the women of age 25 to 64. Now, if you go to choose for the colposcopy for the CIN, you can use acetic acid and iodine. If you choose acetic acid and it stains the cell white, it means the cell are abnormal and that's because of coagulation. And if you use the iodine solution and it fails to stain the cells brown, it means the cells are abnormal and that's because of low glycogen. While you go for the loop diatherapy in CIN, you have to excise up to 7 millimeter deep grifts. If you talk about the cervical carcinoma, 70% of the cervical carcinoma are squamous and 30% are adenocarcinoma. Treatment for the cervical carcinoma, for the initial stage, you can go for the surgery. For the complex lesions, you can go for the radiotherapy. For the 1A stage, you can go with the loop excision along with the loop or cone knife biopsy. In the 1B1, you can use the vertebs hysterectomy, which is just the preferred method. You can also go for the radiotherapy, which is just an additional method. From the stage 1B2 to stage 4, you can use radiotherapy. It can be internal. You can go with the chemotherapy. For example, you can use the cisplatin. And for the palliative treatment, you can go with the radiotherapy. What's the rule for external beam? You'll adjust the dosage at 45. You will give it daily. Each fraction is less than 10 minutes and you're going to do this for 4 weeks. If you talk about the internal or just brachytherapy, you're going to use the selenium rods in the uterus within 5 millimeter of target. Now there's some high-yield information about the ectopic pregnancy management guide. First of all, you can go with the expectant management. In this, the patient should be hemodynamically stable, asymptomatic. Beta HCG should be less than 1500 and the sac size should always be less than 3 centimeters. There should be no cardiac activity in the sac. Second, you can go with the medical management. In this, you'll go for the methotrexate or you can just go with the intracardiac KCN. Now, if you choose to go with the methotrexate, you're going to use it at 50 mg per meter square, or you can just say 1 milligram per kilogram. Now, the patient should be asymptomatic or minimal symptoms are also acceptable. The patient should be hemodynamically stable. There should be no hemoperitoneum. The beta HCG should always be less than 3000. The sac size should be less than 4 centimeter and there should be no cardiac activity in the sac. If you're planning to go with the surgical management, you can go with the laparoscopy. You can also go with the laparotomy and you have salpingectomy or salpingostomy. And after surgery, you will just give 250 international units of anti-D prophylaxis. And this is given only after surgery. Now to talk about the staging, first of all, we get the ovarian carcinoma staging. In the stage 1, you have the lesion in the ovary. Now the stage 1 is divided into 1A, 1B, and 1C. 1A means 1 ovary is involved. 1B means 2 ovaries are involved. And 1C means the lesion is on the surface or the ovaries are just ruptured or there's fluid in the abdomen which is just ascites. In the stage 2, you get the lesion in the pelvis from the ovaries into the pelvis. In 2A, you get involvement of uterus and tubes. In stage 2B, you get all other organs besides uterus and tubes involved. In stage 2C, you get the lesions on the surface or the ovaries or the organs are ruptured with the ascites. In stage 3, you get the lesions in the abdomen. Outside the ovaries, outside the pelvis, into the abdomen. So 3A is for the microscopic lesions in the abdomen. 3B is for the lesions in the abdomen that measure less than 2 centimeter, and 3C is for the lesions that measure more than 2 centimeter in the abdomen. Well, if you talk about the stage 4, it means they are mets, and these mets are found in lungs and liver. Now, if you talk about the staging of the endometrial carcinoma, in stage 1, the lesions are in the uterus. In stage 1A, less than 50% of uterus is involved, while in stage 1B, more than 50% of uterus is involved. In stage 2, the cervix is involved. In stage 3, the regional mets of the endometrial carcinoma are seen. For example, in stage 3A, you're going to have the serosa involved. In stage 3B, the vagina is involved, and in stage 3C, you have positive lymph nodes. While in stage 4, there are distant mets. For example, you will see mets in the bowel and bladder. Well, if you talk about the cervical carcinoma, you have stage 1 in which the lesion is in the cervix. Now, the stage 1 is further divided into 1A and 1B. 1A simply means the lesions are microscopic and 1B means the lesions are macroscopic. So if we talk about the 1A, which are microscopic lesions, it is further divided into 1A1, which means the size of lesion is 7 to 3 millimeters, and 1A2, which means the size of the lesion is 7 into 5 millimeters. If you talk about the 1B, which are macroscopic lesions, you can again further divide into 1B1, which means the size of lesion is less than 4 centimeter, or 1B2, which means the size of lesion is more than 4 centimeter. Then you can have stage 2, which can further be divided into stage 2A and stage 2B. Stage 2A means the upper one-third of vagina is involved, while stage 2B means the parametrium is involved. And then for the cervical cancer, you have stage 3, and again, the stage 3 is further divided into 3A and 3B. 3A means the lower one-third of vagina is involved, while the stage 3B means the pelvic wall is involved. And finally, for the cervical cancer, you get the stage 4, which is just a stage of metastasis, and stage 4 is again divided into 4A and 4B. 4A means there's involvement of bladder and rectum, while stage 4B means distant organs are involved. Now here's a flowchart for the investigation of primary amenorrhea. The first thing you're going to see is the secondary sex characteristics. Now if they're positive or they are negative. Suppose you get the positive secondary sex characteristic, then you're going to see if the uterus is present or not. If the uterus is not present and you get the karyotyping to be XX, it is MRKH syndrome. If you get the karyotyping to be XY without uterus, this is just a female with the androgen insensitivity syndrome. Now let's imagine you have a patient with a primary amenorrhea and you get the positive secondary sex characteristic and the uterus is also present. Now you look for the outflow obstruction, you look for the hymen. If the hymen is fine, imperforate, then you will say it's outflow obstruction. If it's not, you will just call it to be of normal anatomy. Then you will just further investigate for the secondary causes of amenorrhea and you're going to order the FSH, LH and prolactin. Now if everything comes normal, this is just a constitutional delay. If there's increased LH to FSH ratio, it is polycystic ovarian syndrome. And another possibility is if you get the high LH and FSH, it means this is ROS, which is just resistant ovarian syndrome. If you get the high levels of prolactin and that you have to treat the cause, it means it could be a tumor of pituitary gland or something else. And for the treatment of high prolactin, you can use the dopamine agonist, for example, pramipexole, ropenolol, etc. Now let's imagine the other side of the graph in which you have the patient with the primary amenorrhea and you examine for the secondary sex characteristics and they are absent. You get the negative secondary sex characteristic. That you will look for the height of the patient. Now let's assume the height of the patient is short. Our patient is short without secondary sex characteristic and primary amenorrhea. Then you're going to see the FSH and LH. If the FSH and LH both are low, it means there's some infection or the Empty-Sella syndrome or some tumor. But if the FSH and LH are high with a short length, negative secondary sex characteristics and primary amenorrhea, the patient is going to be Turner syndrome. While if you imagine the other side, if you have negative secondary sex characteristics with a normal height, you can go again with the FSH and LH labs. If the FSH and LH labs are low, both are low, it means it's some acquired cause or some hypothalamic cause. It can be because of the anorexia, stress, exercise, or just the Killian syndrome. While if you have the high FSH and LH with the normal height and negative secondary sex characteristics with the complaint of primary amenorrhea, then you will go for the karyotyping. If it comes out to be XY, it means it's just agenesis or some enzymatic failure. If the karyotyping comes out to be of female, which is just XX, it means it's a premature ovarian failure or the resistant ovarian syndrome.